The next presentation will be by Professor INDER RUSTAGI, and he'll be talking about Tear with Care, Deliver with Diligence, CCC in White Cataract and Nuclear Prolapse and Delivery.
Dr. Indermoon also has publications, presentations related to SICS, and he's doing a lot of surgery in a private as well as government sector.
Good afternoon. So after anesthesia and incision making, now it's the turn of how to do the CCC. The part has been covered by Dr. Maurya, and how to deliver the nucleus. So we must aim to achieve perfect CCC, but incidence of incomplete capsulorhexis in white cataracts, they are ranging from 4% to 28% as per literature. And basic principles of the capsulotomy in such cases that we have to have a large opening to accommodate the lens or the lens fragment, and there should be no complication. The CCC should be sufficiently stable. It should be, ideally the IOL should be there inside this, and it should have a single tear that Dr. Maurya has just not told that he can use the swing needle the capsulotomy. And there are two factors, that is shearing and ripping factors. How to guide the CCC. Shearing factor is applied in the direction of the tear, whereas ripping force is applied more centrally. So capsulotomy should be tried using pulling technique in such cases with capsule holding forceps rather than pushing technique, because of in such cases usually the thickened capsules with weak granules are there, and in such cases the challenge is there because of swollen lens, stretched or thickened capsule. There is a liquefied cortex inside, and most of the cases are hypermature or mature cases, so fundal glow is less. So trypan blue is the key which should be used. And in intumescent cases, swollen cataract lens pushes iris diaphragm forward. Because of increased intraocular lenticular pressure in this, the capsule tears to the periphery. So we can do two-stage CCC, we can do C-rexis technique, we can do assisted capsulotomy with femto if available. Not with all surgeons who are doing SICS, femto is not the comfort, the availability or the luxury there. And rather just now Maurya has told that we can do swing needle the capsulotomy. Or if even YAG laser is available with the operating surgeon, we can do a central YAG capsulotomy in that cases, and allow to after that we can take the case to OT. So in such cases we should have adequate bulb block which should be given with adrenaline, and then we can do the staining, and we can do the soft cell technique for if we are having large cataract or hard cataract. So that helps in minimizing the nucleus and avoiding the complications. The surgeons have discussed with milking technique also that before going for delivering the nucleus, we must take out the liquefied cortical matter, and but usually in such cases also again the needle has to be 23 gauge, and then there are so many techniques of doing the CCC. So why CCC in SICS? Because it avoids PCR, and safe hydroprocedure and lens rotation is there. No capsular tear during cortical aspiration, while in zigzag techniques there can be some kind of the complication because of capsular tags. IOL has to be central and stable. There are less chances of decreased PCO if the proper CCC is there and lens is centered. And in case of any kind of the event, that is PCR, IOL in sulcus can be implanted if the intact CCC is there. So that is how the CCC is important in such cases. So next is nucleus delivery. Again, the prerequisite for the safe nucleus delivery is good CCC, and smaller the better it is. The better, smaller the nucleus is there, the better it is. Basic steps is that we have to prolapse the nucleus in the anterior chamber, and then we have to deliver it a proper tunnel or the proper incision. Just now, Madam Rathi has described. So prolapse in AC has to be, best is hydroprolapse, or then we can, yes, we use viscoprolapse, but the incision has to be larger one. The prolapse with Sinskey hook and prolapse in special situation. So nucleus delivery is hydroexpression. The gold standard is blue menthol, where with with irrigating wire vectors. Then viscoexpressions. So many techniques people have modified as per their convenience. Phaco punch or sandwich technique with Sinskey hook, with visco cannula itself, with fish hook technique and snaring technique, and then irrigating Simcoe also. So again, the nucleus, they're doing it bisector technique, dividing the nucleus in 2 pieces, 3 pieces, or multiple pieces, as Dr. Sahu has done with a 2 to 3 mm incision. They are dividing the nucleus in multiple pieces, just like in Phaco also. So hydroprolapse with the nucleus has to be delivered in the chamber, and then viscoprolapse by pushing the visco at the one end at 6 o'clock. We can deliver the nucleus in the chamber. Hydroexpression is basically to alleviate the hydrostatic pressure in the anterior chamber, and then nucleus is delivered in the chamber. The basic thing in hydroexpression is the viscous substance is not used. Then hydroexpression with irrigating vexes. After luxation, the nucleus has been delivered, where visco is put behind the nucleus and above the nucleus. Then irrigating wire vectors is introduced, and after engaging that iris below the hook, the nucleus is delivered. So advantages of the technique is that AC remains formed throughout the surgery, and nucleus, there is no damage to the endothelium. More or less the hard cataract has been dealt by Dr. Maurya. So again, same thing is that, but the tunnel has to be sufficiently enlarged one, and the adequate visco has to be used in such cases. So this is the sandwich technique with Sinskey hook and irrigating vexes, dividing the nucleus in 2-3 pieces. So visco expression, again, we are minimizing the nucleus into smaller size, and again filling the chamber with the visco. Then we can deliver the nucleus. So Phaco sandwich technique again, but in such cases the incision has to be around 7.5 mm, and dividing the nucleus with the visco and instruments, we deliver the nucleus. But in such cases, the more the manipulation is, the more the chances of the endothelial damage. Again, there is the fish hook has been mentioned. Fish hook is very cheap and made with the needle only. We can deliver the nucleus with engaging this fish hook. There is an instrument called the cataract snare also, but again, it comes with experience. So drawback in commonly practiced these techniques is blue menthol or visco expression or wire vectors and fish hook. They all require large incision, and that can lead to the astigmatism. Yes, for the beginners it is good, but once you master this technique, the newer techniques which have been described by Dr. Sahu or Sudhir Singh, that is smaller incision and delivering the nucleus with multiple pieces, they are comparable to the Phaco itself. So conclusion is that similar results in the hands of the experienced surgeons, but ultimate goal is safe delivery of the nucleus, corneal protection, less astigmatism, and giving Phaco comparable results to the patient. Thank you very much.
Thank you so much, Dr. Indamoon, for a very detailed and well illustrated presentation. I would say no, not as good as FACO, better than FACO. Start seeing, because in our OPD, sorry, just one line I'm going to say in between. In our OPD, what we started saying is residents are all laid by FACO. You can put any premium IOL in your SICS surgery. So what happened is, instead of saying SICS, instead of singing that song of mine, instead of that, I just said, all right, let us look at keratometry. You go and do it, so that, my bias is not there. Please do the keratometry refraction of these patients 2 days post-op, 50 FACO and 50 SICS. The winner was SICS. Endothelial cell count as well. So now we are going to start a study on 100, sincerely and truthfully, and see. So we'll that next year.
May I go out? And
Sir.
I'm so glad that I
Sir.
wrote the people and some of the medical policy department. The
Sir, you are the father of SICS.
finest in the country, and I feel like
Sir, पहले
No, no,
photo
doctor,
खिंचाना, ऐसे नहीं।
बेटा अभी वापस
Doctor-
Sir, आ जाइए।
एक वर्ड पे मेरे को थोड़ा ऑब्जेक्शन है रस्तगी साहब बोल रहे थे दिस इज चीप यू कैन से इट इज लो कॉस्ट
I will. So, for those,
Affordable बोलते हैं, sir, affordable.
affordable. For those who doesn't know Dr. Malik is the pioneer in SICS surgery. He is the father of
Not
SICS.
state level, not national, global level.
International level.
Global.
and they were telling me that I learned SICS after being master of FACO, because SIC is more advanced than FACO in every way. Marvelous.
Any patient, anywhere,
And
anytime.
we are honored by with his presence in this session.
To reduce the estimate to correct the estimate.
Yes, sir, surgically corrected. That is
Thank you.
surgically
Thank you
corrected.
very much.
Thank you, sir. Thank you.
Sir, photo खिंचाने you must come back.
Well,